and then he had a decreased total protein and phosphorus, and that could be related to the lack of appetite he'd had. I mean, he's had myasthenia gravis for a while, and it had been worsening to this crisis state, and so of course when you don't feel good, you're not going to be wanting to eat, and if this had been going on for a while, of course the protein, phosphorus, these major nutrients are just going to be a little bit lowered. And that's something that as a registered dietitian that we would pay close attention to, because that's in our area of expertise. And so he'd be consulted to dietary for tube feeding recommendations. So, and again, he's going to be on the tube feeding. We know that he's in ICU because he's in that crisis state. Again, that means they have to be placed on a ventilator, which means they're not consuming anything by mouth, so they need tube feeding to get their nutrition. And so looking at the numbers, he had a dextrose infusion already going, and so that was providing him 408 calories a day. And then these other numbers are just numbers from the ventilator, and those are going to be used when we calculate his estimated energy needs using the next one, which is the Penn State equation, which is what you use for patients who are ventilated, and so you need those for the calculations, and that's just like his rate of breathing and everything. And so that calculation ended up to be 2,445 calories per day is what Mr. W needed. And then he had a higher protein need of 1.2 to 1.5 grams per kilogram. And that's just because he's in a critical care range. Again, he already has a low total protein. And when you're in this intense state, protein is typically a nutrient that your body needs a little bit more of. So you give him a little bit higher recommendation. And so the tube feeding for that would be impact peptide, and we calculated it at a rate of 55 milliliters per hour, and that is going to provide him with 1,980 calories. And you can see that's a little bit lower than the 2,445, and that's because you have to account the dextrose, the calories he's already getting from that. And so we don't want him to be going overboard. Again, he might not be able to even tolerate all of that, and so you just have to account for that, which is why that's lower there. And then typical standard tube feed, you're going to hold for those residuals, and you're going to do fluid flushes. And so as a dietitian, things you're going to monitor and evaluate throughout their stay in there is the enteral nutrition, which is tube feeding, and the diet order. We're going to see if the doctor ordered that tube feeding recommended, what rate it's going at, or if the diet gets advanced, he gets approved. So just watching that closely. We're going to be monitoring his weight, if it's changing, his BMI is, and then we're going to look at nutrition-related lab values, again, like things like the total protein and phosphorus, since those were low. We're going to be watching those closely. Look at his overall appearance, and then once he starts to improve and advance, start to look at his home diet, if he has any food restrictions, and seeing what he's been doing and how we can start to progress and get him back healthy in the hospital and healthy at home. And so at that first follow-up, we see that BMP was back within normal limits, which is great. And then impact peptide, the tube feed that we recommended, was also initiated, which is great. And plasmapheresis treatment is underway. And so the plasmapheresis starting could be a reason why the BMP is back up, because again, he's starting to feel a little bit better. He's getting healthy plasma in him. His muscles can start to work more than they had been. And so heart might have a little bit less stress. BMP is going to go up. Problems though, total protein was still low. The tube feeding was only running at 20 milliliters per hour, which that only provides 720 calories a day, which of course, I mean, this guy's 102 kilograms, 720 calories is not enough to meet his needs, but that also is a big step up because he was not consuming anything at first when he was coming in before and then being placed on the ventilator. But we do see that the patient had lost 2 kilograms, which again is nothing that we want. At the next follow-up, we see that the plasmapheresis treatment ended. So again, that's going to be a 72-hour time span. The tube feeding increased to 60 milliliters per hour, which is right around where we recommended, which is great. We know he's getting all the energy and nutrients that he needs right now. And his total protein is back within normal limits, which is huge because, again, that was something we were looking at the beginning. It was low, so it was an area of concern. So it's probably back within normal limits because his tube feeding is providing all of the protein he needs. And again, plasmapheresis just ended, so his body can start to get back in that healthy balance. He's feeling better, can start to move again, move his muscles. And so from there, you recommend to continue the impact peptide, which is that tube feeding, if the diet doesn't advance. So as a dietitian, you cannot advance their diet since he had dysphagia, so he's going to have to be approved by speech pathology before he can start to have a diet by mouth. And so that's why you continue the impact peptide, and then once it does get approved and he does be able to move on and passes with speech, he can begin a cardiac diet. And we wanted to give him a cardiac diet because of his past history and just like all the stress on his heart because of this condition that he's been having. And so that would be what's recommended next. And then of course, as he continues to advance and is on that cardiac diet, we're gonna provide him education when that's most applicable. At that third follow-up, we see that the diet was able to advance to cardiac diet, which is great. So this is the first time he's able to eat by mouth in a long time. After talking to him, he doesn't have any food restrictions. He's tolerating the diet, and his weight is stable, which is great. Remember, he was losing weight before. And so this is just huge steps. And then in the end, educating patient on the cardiac diet. So that's just going to be a heart healthy diet that's low in saturated trans fats, low in cholesterol, high in those lean proteins, and it's going to be meeting his fiber. It's very plant-based. So that's just educating him on why it's important, why we're giving that to him now, and how he can start to implement that in his life when he gets discharged. So in conclusion, we went over myasthenia gravis. So this is just an autoimmune disease that's caused by an error in transmission of nerve impulses to the muscle. So acetylcholine, again, can't bind to those receptors, causing the muscle to activate and contract. And then we talked about some different treatments. You can do the thymectomy or the different medications, but the main one we focused on is the plasmapheresis, your therapeutic plasma exchange, and how it's just becoming a top mode of treatment for patients experiencing a myasthenic crisis. How more research needs to be done, but it's looking promising so far, which is really exciting. And then we looked at Mr. W, which was our 55-year-old male patient admitted to the ICU in a myasthenic crisis. We went over from when he was intubated, went through plasmapheresis successfully, which is great, and then how the diet would advance with the dietitian going from tube feeding to that cardiac diet. So overall, when comparing, you have the hallmark symptoms of myasthenia gravis. So again, ptosis, diplopia, shortness of breath, dysarthria, weak extremities, and difficulty swallowing. And then Mr. W, he presented with lethargy, shortness of breath, no appetite, and full body weakness. So the ones that you see that are the same, those are going to be what's underlined. So both shortness of breath aligns, weak extremities, full body weakness, which is great. So he definitely did align with some of those hallmark ones. He didn't have like the drooping eyelids and stuff, which is good. I can't even imagine, that would not be great. The difficulty swallowing, he did end up having that dysphagia later because of course he was on a tube feed, so he wasn't swallowing anything by mouth. But also when you account for the myasthenic crisis and how typically you could even have facial paralysis, your head falling from weak neck muscles and everything. So for him to be in that crisis state and not experiencing such severe symptoms that could possibly be occurring was really great. So he definitely is aligning with some of the hallmark ones, doesn't have all of them, but you can still see that he does have myasthenia gravis and was in that crisis state. And these are the references that were used, and thank you.